This was again for those who like reading. I am mostly showing you papers which are clinical researchers. I'm not showing you lab-based researchers because these are more valuable in terms of those who practice. And these are more easily translatable in terms of how you work. So this is another very good paper. This is also, you can just take a picture, look for the title. It was published by Professor John Lin. He published this paper in the journal of the International Journal of Orthodontics. So you can find this journal, and it's a very good paper on how to manage class 3s without extractions or surgery. So it's a very good reference paper which takes into account the patient's profile, it takes into account the class and other factors. So from what we saw before were a lot of, the earlier protocol was for skeletal cases. I'll show you a mix of some cases which look very severe, but it's because they have a functional shift as well. So this was the protocol that we published in the International Orthodontics Journal. It involves just 3 or 4 components. One is dentoalveolar corrections, which means correcting the incisor positions, advancing the upper positions, because in a lot of pseudo class 3s or class 3s, the upper incisors are retrocline or very upright. We used bite blocks and intermaxillary elastics. So if you remember, at the start I talked about the Moyer's classification. So many of these class 3s have a muscle memory, we call it. So we use the bite blocks to deprogram the muscles so that the patient cannot bite normally. And when we proceed to the rectangular wire stage, we start using intermaxillary elastics so that we can correct and bring the mandible to a more improved position. And then the fourth key would be using self-ligation. If you don't want to use passive self-ligation, you can always go in with expanders or anything else. So again, these are 2 very good papers just talking about the diagnosis and treatment or management of pseudo class 3 malocclusions. Can you check if possible, the screen is not very clear, if possible. So some of these images are not very clear. So these are 2 papers which talk about the diagnosis of pseudo class 3 malocclusions. Another one talks about standard protocols. So then I'll just show you simple examples based on these protocols. It's not very clear. It's before, yes, before it was very clear. Now, no. You just, thank you. So based on that protocol, again I'll show you some different combinations of mild to moderate to severe cases. So this patient came in, he doesn't have a very bad profile, he looks okay, he just has class 3 molars, class 3 canines. He has his laterals in a crossbite. So again, whenever you have anterior crossbites, the easiest way to relieve anterior crossbites is to expand, whether with any system. So we just started with normal leveling alignment. Again, bite blocks on the posteriors, and just normal expansion should resolve most of our problems. But you will always notice whenever we have expansion, so just let me go back here, you will see the molars are class 3. When I keep talking about vertical correction, the moment you level and flatten the occlusal plane, you will always see the molars when they upright, the occlusal plane flattens, it automatically starts going towards class 1 occlusion. Then again, we just have to carry out leveling alignment, and it took us roughly about 14 months of treatment time, 8 visits, and we were able to finish again with class 1 canines, class 1 molars, and a flat occlusal plane. This was his pre and post occlusion and his bite. This is the amount of expansion. So again, it's not just expansion alone. You will always notice that your premolars, molars tend to look a bit more upright after treatment. So it's the same combination of a little bit of expansion, some uprighting and some torque expression. And this is his pre to mid and post treatment occlusion. And this is his post treatment profile. And again, the reason why I am showing you this, so whenever I told you I use inter-arch elastics. So as a rule, for most class 3 elastics, before I use these class 3 elastics, I always get the third molars removed. So that helps you in a number of ways. Whenever you remove the third molars, one, it unlocks your second molars, so you can actually gain some transverse expansion space with the second molars. This is in the transverse plane. You also get better uprighting of the 6 and 7, which is sometimes very difficult when you have 8s behind. So it allows for mesial to distal uprighting. This helps you in a number of ways when you talk about biomechanics. When your 6s and 7s upright, it gives you better control over the incisors. So your incisors are usually more upright. And then, because you're expanding at the same time, you also can level the arch without proclining the incisors. So you have a number of ways that you can gain space and also make treatment much easier. And then by the time you reach the stainless steel wire stage, when you start the elastics, you will start to see the elastics are more effective because you are trying to distalize the entire arch. If you use elastics with the wisdom teeth, there is no way for the teeth to go. So in those cases, sometimes you will start to see extrusion of the 6 and 7. But if you remove the 8s, it becomes relatively easier for your arch to distalize. So as a rule, I always like to get the 8s removed before treatment, especially before I start the use of inter-arch elastics. Here and then you always have the option to get the 8s removed during treatment, after treatment, or at any stage. And this is just a composite of the whole treatment from pre to mid and post treatment. So adult cases, we have few options for expansion. So class 3 patients, it's always favorable to expand. Whether we use rapid or slow expanders, I think we covered that a little bit in terms of the patients developing problems on the buccal aspect. I think yesterday we were discussing expansion. Then we have the option to use over-expanded stainless steel wires. I normally never recommend using over-expanded stainless steel wires because these cause a lot more of posterior segment tipping. When you have posterior segment tipping, it's a lot more difficult to correct than anterior tipping. We have to make space with IPR, sometimes use mini screws to constrict the arch, or use under constricted arch forms. But it complicates the treatment a lot, which is why these are my lesser preferred options. Then you have cross elastics. So cross elastics work very well for single teeth, but they don't work very well when you have a group of teeth that you're trying to either expand or correct the cross spikes, specifically your posteriors. So my preferred option for my own experience is always, I prefer to use self-ligation just because I know the troubleshooting and I know the workaround. So this is the protocol that we developed and we published in International Orthodontics, which talks about advancing the upper incisors, deprogramming the muscles using bite blocks, and bringing the mandible to a better position using elastics. So in this case would be class 3 elastics. So this gives you very good correction in a majority of pseudo class 3s or muscular class 3s. So for us, the most important thing would be to achieve very good vertical control in these kinds of class 3 patients. So vertical correction, again, this is a very good reference for those who would like to read more. This was, again, a very good study comparing different kinds of vertical occlusions. It highlights the same things that I was trying to tell you. In class 3 or class 2 patients, we should always try to correct vertical planes first. It always helps reduce the severity of the class 2s and class 3s. So for me, as a rule, if I have a deep bite or an open bite, I would never start space closure or go into working phase. As a rule, I will always carry out leveling first, make sure my occlusion planes are flat. Then is only when you know the true extent of the malocclusion. So we only start working phase after correcting an open bite, correcting a deep bite, is when we would enter the second phase and try to move teeth bodily. Otherwise, in most cases, you will see that we go wrong somewhere. We are left with an overjet excess. Sometimes we don't finish in class 1 canines. So our priority always should be to correct the vertical plane first. So again, I like my motivational quotes, so I try and keep putting this everywhere. So again, in terms of ortho treatment, unless there is literally no bone, I don't foresee a situation where we can't provide treatment. Our priority is to help patients by improve their quality of life. There are many ways we can do that, many options in terms of biomechanics, brackets, aligners, there are many ways. But there is always a way to do something. So then I'll show you another example, which is an adult patient with missing mandibular molars. So I showed you the case report we published, which was talking about protraction across knife edge ridges. So again, as a principle, I only protract molars if the extraction spaces are there for less than 2 years, maximum 2.5. Anything more than that, I would normally just upright the 7th or the second molars and let the patient get implants or restorations. Because after this much time, let's say if the patient is beyond 2.5 years, one, the buccal-lingual width of the alveolar bone is lesser. Second, the nature of the bone itself becomes more cortical. So it's very resistant bone, which is why we don't recommend using or trying to protract the molars anteriorly. So this patient, again, she came in with an anterior crossbite. You can see she has almost class 1 canines with no molar relation because she's missing her first molars. So this was her pre-treatment ceph. So you can see that she already has one mesial tipping, and she also starts to show some signs of alveolar bone loss. So she has vertical bone loss and a slight deficit or a defect mesial to the second molars. In these patients, if you try to protract, you will just see that the molars tend to become more mobile or the bone defects usually tends to become bigger. So this was her pre-treatment profile. You can see her smile. So there are many options to upright the 7s. So I thought I'd show you a report within a report. So one of the options is to use cantilevers. So we were discussing some cantilevers before. So these are some of the commonly used options. You have cantilever springs, you have distally placed stats, you have T-loops or L-loops for uprighting, or you have open coil springs. There are benefits and problems with all of these. So one, if you place a retromolar pad screw, you actually have to open a flap so that you can place it properly. Otherwise, there is sometimes a risk of slippage or breakage of the retromolar pad bone. Then we have the open coils and the night eyes. I don't like using night eyes to upright 6, 7s or 8s because it tends to extrude them during the uprighting process. So for me, my preferred options usually is either using cantilevers or using loops. So cantilevers would be somewhat like this. So we have at least a base 1725 stainless steel and also a cantilever spring using a 1725 stainless steel with a hook and a helix. But this is again a bit difficult for the patient sometimes. So in this patient, I decided not to use this. I decided to go ahead with loop mechanics, which is using an L loop with uprighting helices and tip backs. So the benefit of using this over night eyes is, whenever you use night eyes, one, it will upright, but it also extrudes the molars, and it also allows for your anteriors to procline. Whereas when we use loops, they will upright the molars. It's usually on a heavier stainless steel wire, so it gives you vertical control, so your molars don't tend to extrude easily. And because you have tip backs, so when your molars upright, they tend to bring in your incisors as well, which makes it much better in terms of uprighting and not proclining. So if you just look at the incisors here, I will show you that. Just keep looking at the lower incisors. See the next visit, when you look at the incisors, they look much more upright. So every time your second molars upright, you also get an uprighting effect on the anteriors. So we are also helping get the patient into a proper overjet, and at the back it's essentially acting as a space maintainer, so that once the patient is in the finishing stage, you can get her implants placed or restorations done. So once your molars are upright, you can directly proceed to using a straight stainless steel wire. At this point, we just have to settle the occlusion. The patient can receive the implants, and the patient can receive her restorations once we debond. So once we evaluated the bone, we also saw that she has very knife-edge bones. So we just decided to finally give her implants on one side, and we restored the other side with a bridge, because it was too difficult to augment that much with and use implants. So the patient eventually decided to go ahead with a bridge. And so this is her pre and mid treatment. And this is a composite image of how to use these loops. So one of the options, the easier, that's why I told you there is an easy option and there is a better option, just that it takes time. So easy options, just use night eyes. The whole problem with night eyes is it would bring about a new malocclusion, which means you have, and now you have an increased negative overjet, so you have to start thinking of using screws, any appliances to retract, so that will just extend your treatment time as well. So since we can't move teeth faster, we try to find ways of minimizing problems that may occur. Which is why I told you, whenever I have problems, I would usually think of bending wires, because it's more precise and it gives you much better effects. So again, I thought I would show you another option with class 3 patient with a can. So now you can see she has a vertical problem and a canted profile. You can see on the resting position itself. You can see her upper lip is hypotonic, her lower lip is protrusive. So we have a classic class 3 problem again. So then, if you look at her profile and herself, again you can see that she has, the main problem is that your lower lip ideally should be just resting below the incisal edge, which means it should be somewhere here. But whenever you have an increased negative overjet, your lower lip tends to go more anterior. So what we want is for us to get into a positive overjet, so that our upper lip has support, but also our lower lip can go back to its resting position. So this is what we want to treat with her in cases of class 3s. We just want support for both the upper and the lower lips. So this is her intraoral pictures. So if you look at her intraoral pictures, again you can see she has crowding in the maxilla. Her lower arch actually looks well aligned, but she has grossly decayed molars. And you can see that she has a canted occlusion because on the right side, you can see she has a deep curve of speed. On the left side, it looks relatively flat. So again, many of these problems we try to take either PA view steps to check first if the patient has a skeletal problem, a dental problem. If it's a dental problem, it's relatively easier because we can correct this with just bracket positioning. But if it's skeletal, then we think of one segment being intruded using tags or some form of appliance. So we just started leveling and alignment for this patient. This is her pre-treatment panel. When we carried out the analysis, it again said non-extraction preferred. But then, because we were planning to gain space with expansion, so I still decided to remove all her aids. So we decided to remove her posteriors, and we started with just normal leveling alignment for her. And again, this is before removing the aids. You always see that you have limits in terms of molar uprighting. Once you remove the aids, you will see when your 6s, 7s upright, you will find it much easier to see the anterior start to upright. So few months later, when we move towards heavier wires, you can see that we have much better uprighting of the anteriors. The molars are in a much better position. I normally, if I'm using these elastics, I also like to use small power threads sometimes. So we just have to tie these by hand instead of using power chains, but they give very light continuous force. So we have different companies have these power threads which you see in the upper canine and the upper premolars, because when you keep expanding, sometimes you will notice spaces open up. So I just like to use these small power threads and then continue the patient on elastics. And this is her pre and post, pre and the mid treatment photos. And we were finally able to finish her with, again, class 1 canines, molars, and a proper occlusion. And we just, for the lower arch, we just restored everything. And you can see the third molars were removed. So again, that allows always for better uprighting for the 6s and 7s, and it allows for more movement with the elastics. And this is her profile at the end of treatment. So now you can look at her upper lip and lower lip profile again. So now since she has better positioning for the upper incisors and for the lower incisors, the lower lip can go back in and the upper lip goes a bit outside, and you can see her profile at the end of treatment. So you can see her pre-treatment profile and the difference between her post-treatment profile. So we have a flat occlusal plane now. We also have a better nasolabial angle, and you also see the lower lip resting at its normal position. So we try to get the lower incisors in an improved position so that we can get a soft tissue profile change for these patients. So again, it's more about the diagnostic side. There are many ways to do this. If, let's say, if I wasn't using expansion, I would have thought of maybe carrying out lower extractions to retract, because it would have flared out for sure. And this is her pre, mid, and post-treatment smile. So you can see again she gets a positive smile arc. Then I thought I will show you again a similar variant again. So in this case, a slightly different profile where her upper and lower lip are not so protrusive, but it was much more severe when we looked at her intraorally. Here, so it looks here. So you can see this is her pre-treatment self versus her pre-treatment profile. And this is her pre-treatment occlusion. So again, you see class 3 molars, you see distally tipped class 3 canines. So these are a bit more difficult to upright. Again, sometimes we have to bend, sometimes we have to make sure that we bond the brackets with a slight tip so that we can upright the canines. And then again, our solution was, when we carried out the analysis, we still wanted to remove the wisdom teeth so we can expand the upper and the lower arch, and we also start the patient on elastics. So this is just her mid-treatment profile. This is how we started out. So for adult patients, I normally use similar protocols for anterior crossbites. I would normally just bond the upper arch, use posterior bite turbos on the lower arch, just disocclude the anteriors so that we get the crossbite corrected first. Then we just have to level the lower arch. So you can see this is her initial to mid-treatment photos. Then this is after leveling and aligning the lower arch. So at this point, you see again, once we correct the occlusal plane, we correct the occlusion, you will see most times the molars start going towards a class 3 relation directly, class 1 relation. Then we just have to settle the occlusion, make sure our occlusal plane is flat and it becomes more stable. So we were able to finish with again a positive smile arc. You can see a much better soft tissue profile for the patient. And this is her post-treatment occlusion. So again we finished with coincident midlines, class 1 canines, class 1 molars, and a settled occlusion. So again our priority is as much as possible to try to reach flattened occlusal planes and good stable occlusion. And you can see, again we removed the third molars because it allows for better uprighting of the 6s and 7s. That allows you more control over the incisor inclinations, which we can use to our advantage, specifically in terms of class 3 malocclusions. And this is her pre, mid, and post-treatment profile smiles. And this is her soft tissue lateral profile. And this is her pre and post treatment self. So you can see we have a very good uprighting of the incisors. So the way we plan treatment, this is a very important paper that I read many years ago, but it does influence a lot about how I like to work. So which is talking about the soft tissue paradigm. So for those who don't know, for many years what we used to follow was the angles paradigm, which means we were only concerned with class 1 canines, class 1 molars, and it's only focused on hard tissues. These days, again, I think most of you know because of your practices, patients come expecting a complete change. Every patient walks in thinking like they want to walk out like a celebrity. That's the drawback of too much social media is one problem. But then we also try to focus a lot on stability with regards to the soft tissue envelope. Which means, the reason why I keep focusing on incisor inclinations, angulations, it's very important in terms of stability. We want the incisors upright because it balances out the forces between the tongue and on the lips. So you also help get stability at the end of treatment. So what we do pay a lot of attention to how we plan treatment with regards to patient profiles. So for us it's very important to look at profiles before plan treatment to make sure patients look much better. So we have all mild, moderate, severe patients with different kinds of profile problems. So which is why we considered using this protocol. It took us almost 12 years of work to develop this protocol and refine it continuously. In the beginning, we used to finish a lot of patients with a slightly deep curve of speak, so we had to find out more ways to level, and finally we came up with an approach where we could treat these patients with a flattened occlusion and use just simple methods to correct class 3s. So again, I thought I'll show you another example of this kind of profile. So this patient came in, again she had a severe problem. She has class 3 molars. She has an anterior crossbite again. I think it was almost extending to the canine on the right side. So here, what we want is again to get the patient to a positive overjet. But then if it's not visible in terms of her profile problems, so she doesn't have a maxillary incisor display. So what you see is only her mandibular incisors because of the crossbite. So her main concern was really aesthetics and she wanted to smile better. So again, when we checked her records, you can again see that her point B is ahead. She has a negative A and B angle. So we have to find ways of correcting her profile, get her to a better overjet, and also try to fix her smile. So this was her deviation from the normal on software evaluation. So again, we use the same protocol. We expand the upper arch, use bite turbos, then wait till rectangular wires and we start elastics. So we started in the beginning, it took us about 10 months of treatment time to jump the bite. We kept progressively decreasing the bite turbos, and once we were on rectangular wires, we thought of starting elastics for her. So most class 3 patients, the moment you have better support, you will already start to see a change in the soft tissue profile. So then thereafter, we just have to make sure we make the profile as conducive as possible. So when we remove the bite turbos, we decided to bond the 7s. So this is roughly at about the 14th month stage. So at this point, you can see her molars are almost class 1 on both sides. So again, if you looked at her profile in the beginning, she had a deep curved speak. Once you level the upper and the lower arch, you will automatically see that the mandible starts to go to an improved resting position. Then we also knew at the beginning that she had a Bolton's deficiency in the anteriors. So if you look carefully, you will see that she has microdontia in the anteriors. So which is also the reason why she has class 2 canines. So when these patients, whenever there is a Bolton's deficit, you will always see there is a problem getting canines to class 1. So we had to compensate for this. So the easiest way we could think of was, we just decided to open up spaces between canine to canine, just place simple open coil springs, so that we can open spaces and then build up to correct the Bolton's deficiency. So at about 15 months, we were able to finish her treatment with, you can see the increased mesiodistal width after we opened up spaces and just carried out direct build-ups. So this was her profile change at the start, mid-treatment and post-treatment. So you can see she has much better profile now, a very good balance between the upper and the lower lip, and also you can see her x-rays and you can see much better uprighting of the posteriors. So again, this is her self-superimposition. So the protocol involves correcting the retroclination of the uppers, correction of the occlusal plane, deprogramming of the muscles, and use of inter-arch elastics. So you can see this is just a composite image of how her treatment went. And this is her overall treatment progress. So from how we started with a completely negative incisor display to moving towards a positive display. Okay. So I thought I'd show you more examples of pseudo class 3s. So pseudo class 3s often present like this, where you have If you look at the premolars, you will always see the premolars are slightly nasally tipped. The reason for this is sometimes when the patient loses the deciduous teeth early, the permanent teeth the molars specifically start to tip nasally. Thereafter, whichever premolars erupt, they will always be nasally tipped, which compromises the occlusion and brings about a mesial shift, which will just slide the mandible forward. So for us, we have to correct the problems we see, but we also have to correct the premature contacts by proper leveling. So again, this was her nasolabial angle. Her occlusal plane was not flat, as you can see. So we just wanted to correct her occlusion. So we just started leveling alignment for that patient in the upper and the lower arch. So the good thing about premature contacts is if you bond your brackets at the long axis at the right height, you don't have to worry so much. Most of your problems tend to correct just with leveling. You will see that the mandible already starts to go to a better position. Then we just have to stabilize the occlusion by moving to heavier wires. So at about 8 months, we placed her stainless steel wires in because now we wanted to stabilize the occlusion. You can see that once the teeth start to erupt in the right position, you will see that she already goes towards class 1 canines, class 1 molars. So we just have to settle the occlusion and stabilize it. So this is roughly about the mid-treatment stage where we saw this much of correction of premature contacts. Then we move towards finishing. So it took us roughly about 14 months of time to debond. And this is her pre and post-treatment occlusion. The patient was not willing to get her sevenths removed, eighths removed, which is why you again see the drawback of using elastics. So when your patients don't agree to remove their eighths, you will always see extrusion of the sevenths. So again, this is just the post-treatment Ceph and Pano, and this is her superimposition. So you can see we managed to keep very good control over the incisors. Just the upper incisors were proclined to get a positive overjet, but again and again I was reinforcing the removal of eighths so that it allows for better uprighting of the sixes and sevens. And this is her pre and post smile line. So she has a positive smile line, and this is her composite image. So you can see how it progressed from start to finish. This is just her summary. Then I'll show you again another example. So I have at my practice, if conservatively, I think I have half my patients are class 3s. So I don't have many good friends because when my friends have class 3s also they send it to me right now. So I have about 10 clinics which are within 1 kilometer of my practice. So I get impacted canines, I get perio problems with class 3s. I do get a lot of class 3 patients. So I have been working with class 3 patients for a long time. So again, this patient came in again looking to correct his smile. So you can again have a look and see that the patient has a negative overjet. He has an anterior crossbite. Whenever you have an anterior crossbite, you will always see the lips don't have support. Whether it's the upper lip or the lower lip, they will always look not supported. So we have to correct the incisor proclamations. This was just his intraoral records. Again, you will see a little bit of a vertical problem here. So if you look at his face here, again you will see a very slight cant here. He has a slight vertical problem as well, which is again because of his occlusion. So if you look at his bite on the right side, you have a crossbite on the entire right segment. But if you look at the left side, you have slightly over extruded posteriors. So again, we have to level both the upper and the lower arch, flatten the occlusal plane, and we try to get the molars and the canines back to their normal position. So he also has a shift. So again, these are the keys I keep reinforcing again and again. We have biturbos for disocclusion of the anteriors. We have inter-arch elastics to bring the lower arch back to a more normal position. We carry out a little bit of transverse expansion and leveling so that we can correct the crossbites. And at the end of treatment, we need very good settling so that we can stabilize all the changes we have carried out. So again, just disocclusion should give you a lot of correction. So you will see that once your arches start to level, again sometimes the midline shifts are just because of the contacts. So when you when you carry out proper leveling, you will see that the mandible again starts to go to its normal position. So at this point, we just have to keep moving towards bigger wires and we try to finish in stable occlusion. So these are again his mid-treatment pictures. Once you get into a positive overjet, you can see he has a much better smile line, much better incisor display. So we just have to carry out and get better dock expression, and we finish with proper, again, class 1 canines, class 1 molars, and proper overjet and overbite. And again, you can see that we've removed the third molars. So the benefit of having the third molars removed is getting your molars into a much better improved position. So we just wanted uprighting of the lower segments so that we can use the class 3 elastics to their maximum benefits. And this is his post-treatment self. So you can again see, once we use elastics judicially, even with expansion, ideally we should not get proclination. We try to finish with as stable a position for the lower incisors as we can. And you can compare his pre as well as post-treatment self. So you can see now we have a much better support for the upper lip, much better support for the lower lip, and we have a flat occlusion plane, which is what we desire in terms of stability for a class 3 case. So again, we focus a lot in terms of not only correcting the patient's problem, but also looking at what we can make more stable in the long run. Because you will go to a lot of conferences, events where they tell you you should go in for lifetime, nighttime retainers. That is because of movements which are exaggerated. But if we just look at the cause and effect relationship, we try to correct everything just using basics, you will see it is very stable in the long run. And this is his pre to mid treatment and post treatment smile line. So you can see the patient looks aesthetically, and he has a much nicer smile. And this is a comparison of his pre-treatment as well as post-treatment smiles. So I thought I was showing you some mild to moderate cases. I thought I'll show you some more variations of impacted canines. So I think we still have a few more cases to go. I'll try and see if we can show you more. So again, we had a patient who came in with a vertical problem. So patient has an anterior crossbite. You can see his point B is ahead. In this patient, you can also see on the left maxillary segment there is a missing canine. So his canine was palatally impacted, and then he had a grossly decayed second premolar. So what we decided was to remove the grossly decayed second premolar. We wanted to distalize the first premolar and try and gain space with a little bit of expansion for the canine. So I normally try to raise bites as much as I want to, as long as it helps me jump the bite. Otherwise, I would just keep gradually leveling and then jump the bite at a later stage. So a few more months of leveling, you can see now the arches start to flatten, so it starts to look better. And when you see the arch look better on the right side, you will already start to see much more improvement in the canine and molar relationships. Then this is the journey which I'll show you in clinical pictures for the palatally impacted canine. So this is just to show you that there was a palatally impacted canine which we were trying to bring out. So initially, this was published as a case report some time back. I published this in, it was a modification of a Kilroy spring. Normally for a Kilroy spring, you have to, either you can buy it commercially, we have lots of options like an isoglide, or you have to use auxiliary wires. We decided to just bend and make our own spring. So which is what we developed. So we again developed a spring. This was our own design from our faculty. So we designed this with a triple helix so that we could turn this into a spring design which would just gently bring the canine out into occlusion. The reason why it's on a single wire is when you try to compress this, it will work two ways. One, you will see some angulations below the helix. So it tries to make sure that your lateral and your premolars cannot dip easily. But it also works like a spring so that when you keep on pressing it will try to gradually bring down your canines. So it helps you maintain that space, so you don't need to use open coil springs. It will help you maintain space and bring out the canine. So some more months we were able to see the canine in the arch. So at this point we just decided to go ahead with couple mechanics so that we can derotate the canine and get it into a better occlusion. So on the right side you can see we already have class 1 occlusion. Then after derotation you can see now we just have to settle the occlusion and finish. So this is just how the canine went from being placed in the palate to being for the space opening up for the canine, the disimpaction loop for the canine, and gradually bringing it into occlusion. So this is just a GIF that we created just to show the canine coming into occlusion. And again you can see, once you get into a proper overjet, you will always see the patient's soft tissue profile looks better. You have more lip support for the upper and the lower lips. So again, whenever you have severe class 3s, you always have a preference. Whenever you level the curve of speed, you will always see much better occlusion and the severity become much lesser. So to show you another example again, we have another patient whose soft tissue profile actually didn't look that bad, but he had an anterior crossbite and as you can see a deep curve of P again. So we were again left with a challenge on how to treat him. So you can see how this is his CEF. So again, when we looked at his CEF, we were figuring out what would be the best option to get him into a positive overjet. So we decided once we analyzed this, the extraction index still said non-extraction. So we thought of again removing his aids to try and get him into a proper occlusion. So again, we just carried out this occlusion. I normally don't rely so much on patients to use bite trains because they tend not to wear them. So I would just go with a fixed option and just go in with this occlusion and a very small wire, and we keep reducing the turbos. Another 3 months, we get the patient into positive overjet, so we just have to start to level and align. On another 4 months, you can start to see on the right side the occlusion settle more. So now we're just waiting for the other side. Then another 4 months on a 16-25. So you can see the bite settling down on the right side. We still have more work to do on the left side. But you see, this is how much of just uprighting effect we have. So when it's not just expansion alone. When you see proper arch alignment, when you see uprighting, when you see proper dentoalveolar expansion, you should still look at the bone, always look for fenestrations there, since you should always see whether the bone looks healthy or not. This is the lower arch, and you can see he again gets a much better smile line and a much better profile. So again, most times our idea is to try and correct the soft tissue mask of the patient. by trying to bring the incisors into a better position. And you can again see we still didn't manage to procline the anteriors. So you can see we have a very stable position for the incisors. It's a simple protocol that we developed which gives you space to level the arch using some of the dentoalveolar expansion protocols we have. So you can get simultaneous correction, which means again if you look at the images, we are just carrying out leveling. We haven't started using elastics. When you correct the vertical problems, you will automatically start to see the mandible go to a better position. Here. Then we have, I'll show you another variant, not a class 1 slide. So this is again a class case with class 3 canines, class 3 molars. This was more of a dental class 3 problem with a bimax profile. So the patient was looking for a profile change, but her profile was very convex. So whenever the patient has crowding, proclination, profile correction, we always think in terms of extractions. So this was her pre-treatment self. So you can see that her upper and lower incisors are proclined. She was already high angle, so this was just complicating things for us a little bit. So we decided to extract her upper and lower teeth. The major problem with this patient was that she only had about 16 months of treatment time and she was looking to move to the US. So we essentially had to finish her treatment and space closure. So which is why for the lower arch, we started canine retraction and used closing loops. For the upper arch, we decided to use a combination of closed closing loops and keyhole loops that we could activate at the same time so that we could distalize the canine and have enough torque control to retract the anteriors. So we wanted enough control over both the anteriors as well as the canines. So we managed to close space. This is roughly at about the 1 year period where we closed spaces. Now we have class 1 molars, class 1 canines. She also has multiple decays. Her anteriors, she also had PMMAs which we had to fix. And finally we were able to finish her with class 1 canines, flat occlusal plane and class 1 molars. And this was her pre and post smile. And this is her pre and post self. So again, we tried to get the incisors in as stable a position as possible. She was already high angle, so we tried to just maintain and not increase it more. And this is a composite image of how her entire treatment went. So again, I thought I'd show you some of the complex cases that we handled. Maybe 1 or 2 cases. Is that okay, or do you want me to finish? What is okay? Is it okay to continue for 10 minutes more? So I thought I'd show you another case with bilateral transposed canines. So the patient's profile was not that bad, but she had bilateral maxillary transposed canines. So we were looking at ways on how we could correct this. Class 3 molars. She was again referred to us from another practice who, when they took records at bonding, they found out that she has bilateral canines. So this was her upper arch. You can see she has retained deciduous teeth and a little bit of lower arch crowding. So we again just took all her records. We thought we'll evaluate them and plan. And you can see the canines lying on top of the centrals. So I mentioned this statistic in the beginning. If your canine is on the mesial side, it has a 64% chance. If it's on the distal side, there's a 91% chance of success. But there were another guidelines which were published. Again, this is freely available on Google, so you can just search for the guidelines for impacted canines. This took into account the root apex position, whether it lies in the space between the lateral and the premolar, on top of the first or on top of the second premolar. So when we used this classification, we found that on the left side, it was almost at the border of the yellow and red. On the right side, this was at the border of the green and the yellow. So again, if you remember, I mentioned at the start of the session, we always try to correct the angulation first before we try to bring the canine down. So normal methods would be to use a punch, open a flap, but then when we carried out CBCT analysis, we found out that the patient had very less bone. So we decided to go ahead with a little bit of technology. So this is one part of the paper which was published, which is extended reality in dentistry. So one of the co-authors is Dr. Viet, who is sitting here in front in the corner here. So we developed some models for this patient, which was specific AR models. So once we converted the CBCTs into the AR models, they look like this. So now you can visualize you have more bone here, but you have much lesser bone here. So then we decided to not use the techniques which I just showed, and we just wanted to carry out pinpoint exposure. These 3D models are scannable with your phones, and you can just open them up anywhere. The patient can visualize them. So our plan was to remove the third molars, just use tags. We decided to use 2 mini screws so that we could correct the angulations first, then try and bring the canines into occlusion, and we decided to go ahead with removal of the aids again. So we used, again for most impacted cases, I always prefer to use the E-thread which I was mentioning before. It's a very light thread that you can use like a power chain, but it gives much lighter force. So our idea was just to try and move the canines away from the roots and try to correct the tip on the canines. So 6 months later, it took us about 6 months to improve the angulation of the canines. And for the lower arch, we were just leveling. For the upper arch, we were just waiting to remove the molars before we bring the canines down. So about 12 months into treatment, we decided to bond the upper arch, leave the laterals free, again use piggyback mechanics or auxiliary wires. So we have heavy base wire and a very small piggyback wire. About 16 months into treatment, we were able to bond the canines. We placed the brackets on the laterals upside down just for more torque expression. 20 months into treatment, we managed to bring the canines down. So this point we started to use class 3 elastics and rainbow elastics to close the bite and settle the occlusion. And we debonded at about 25 months. And then we proceeded to scan her to just correct the torque on the canines. So this is how she went from bilateral canines, impacted canines to normal canines. Yeah. And this is how the whole process went. And this is her pre and post self. So you can see she has a much stable occlusion at the end. She has very upright incisors at the end of treatment. And this is her post-treatment self and her profile at the end of treatment. So the last case, I'll just finish with this. I thought I'll just show you a complicated case at the end, and then I'll conclude the session. So this was a patient who came in with the reason why I thought of showing you this is, most times scoliosis has always been associated with class 2 malocclusions. You never find scoliosis with class 3s. So in fact, there is literature which says that scoliosis is always associated with class 2s. So this patient came in, unfortunately she was a class 3 patient now, who had an anterior crossbite, and it doesn't look this bad outside, but it will look much worse when you see her intraoral images. So intraorally, she has a collapsed lower arch. You can see the mandibular arch is completely restricted. The upper arch, her molars are missing. And you can see her, we call this a collapsed bite because you don't visualize the lower posteriors. and she has very over-adapted posteriors. So again, our plan was to try and see how we can improve this. So one, we wanted to expand the lower arch. So this was the superimposition I was telling you about before. One, we need to upright, we need to expand, we also need good torque expression. But that happens within limits. When we have to carry out a lot of uprighting, you sometimes need to use skeletal anchorage. So for the upper arch, we just bonded brackets, we started leveling. For the lower arch, I'm not sure if it's visible, but we removed the aids and we have screws here as well as here. And we were just using it to slingshot the power chains around the wires so that we could get an uprighting effect on the posteriors. We wanted to expand as well as upright, and she was also using crossbind elastics, so you might see lingual buttons here. So there were three kinds of movements we were trying: expansion, uprighting, as well as the crossbind elastics. So it took us about 20 months of treatment where we could get the patient to a proper stable arch form, class 1 canines, and then we started placement because we could not, the molars were missing for a long time, so we decided to place prosthetic implants. And roughly about 27 months of treatment time, we were able to complete her treatment with class 1 occlusion on the right side, left side class 1 canines, and she got an implant placement done on the left side. And this was her before and after. And this is her arch pre and post treatment. And this is her post-treatment smile. So she was a very happy patient. You can see the deviation on her neck. So she was still receiving treatment for scoliosis, but she's much improved now in terms of her general health as well as orthodontic health. So this was a comparison of how she came and how we managed to help her. And this is just a comparison of her pre and post arch forms. And this is just a composite image of how our treatment progressed. So these are some of the, I think some we've seen, there are many more that we plan with camouflage. So I would like to conclude just by saying, again, we as orthodontists have a duty to provide patients a better quality of life. Expansion is very favorable in many of the cases, not all, because it allows the tongue to go to a slightly higher resting position. Again, for many of these options, surgery might be a better option, might be more stable, but because the patients don't have that option, sometimes we don't have that option, is why we carry out camouflage. And again, in most of these cases, I always recommend acrylic retainers because the clear retainers are too soft to give you retention. So just for retention, preferably always use acrylic and metal-based retainers. So in terms of learning, this is the best way to keep improving. We try to keep learning, try to keep improving, and wherever possible, we try to innovate and invent. So with that, thank you for your attention. I hope this was valuable for all of you.